Hello, everyone. My name is Sasank. I'm a fourth year med student. Today, I'm going to be talking about wide complex tachycardia and the management and diagnosis. So, we've discussed neurocomplex tachycardia in the previous video. In this video, we're going to be discussing wide complex tachycardia. So, as a definition, wide complex tachycardia is a rhythm that is greater than 100 beats per minute. The QRS complex width is greater than 120 milliseconds or 3 small boxes. The differential for this is most likely ventricular tachycardia 80% of the time, or SVT with aberrant conduction. Could also be pre-excitation syndrome or pacemaker mediated tachycardia. So when evaluating our differential, there are defining features that makes VT more likely and others that make SVT with aberrancy more likely. So the pertinent positives for VT is very wide QRS, so greater than 4 boxes or 160 milliseconds, rate greater than 120, new northwest axis in which both leads 1 and 2 are negative, AV dissociation in which the ventricular rate is greater than the atrial rate. There's concordance in which all QRS in V1 through V6 are positive or negative. Any fusion or capture beats. Fusion beats are when there is a hybrid QRS that looks both normal and wide. And capture is when there is a normal looking QRS in the middle of a wide complex tachycardia. Other positive criteria is the Basel algorithm, which states that if greater than or equal to 2 criteria out of 3 are present, then it's most likely VT. The first criteria is high-risk substrate. So if there's any prior MI, any heart failure with reduced ejection fraction, less than 35%, prior VT or ICD, implantable cardioverter defibrillator. And second criteria is lead 2 time to first peak is greater than 40 milliseconds or 1 small box. And third criteria is AVR time to first peak 40 milliseconds or 1 small box. So this is very effective, is 93% sensitive and 90% specific. There's also the Brugada algorithm. So the Brugada algorithm will help you differentiate between VT and SVT. So this is a little bit blurry, but I'll just read it out to you. So if there's an absence of RS in all precordial leads, if yes, then it's VT. Otherwise, it's SVT. Otherwise, SVT, there is no absence of RS in all precordial leads. If the R to S interval is greater than 100 milliseconds in one precordial lead, in VT this is yes, in SVT this is no. If there's signs of AV dissociation, then in VT it is yes, if SVT it's no. If the QRS morphology is consistent with VT and leads V1, V2, and V6, in VT this is yes, in SVT this is no. So the interpretation of this algorithm is the answer to any of these questions is yes, it's VT. Otherwise, if none are present, it's most likely VT. So now I'm going to be talking about the pertinent positive for SVT with aberrancy. So if there is a known bundle branch block, so any right bundle branch block, left bundle branch block, or IVCD, then with similar morphology and axis, then as seen on prior or baseline ECG, that could be SVT with aberrancy. If there's any evidence of His conduction in which the QRS has sharp initial deflection, that could be SVT with aberrancy. If there's a pre-excitation on baseline ECG, this supports the antidromic AVRT or pre-excited fibrillation. This could be signs of SVT with aberrancy. If the R wave peak time is less than 40 milliseconds, this is also positive for SVT with aberrancy. So why do you need to know this? It's not so important that you diagnose exactly what it is. It could help the management, but if there's any doubt, treat it like it's VT. So VT is generally more serious. You want to consider any underlying processes like active ischemia, coronary artery disease with scar, any electrolyte derangement such as low potassium and low magnesium, any indwelling lines. So you want to check and replete the electrolytes. You want to have potassium greater than 4 and magnesium greater than 2. You want to review the baseline ECG for evidence of long QT or pre-excitation. That does help the management a little bit. So then what is the morphology of the ventricular tachycardia? If it's monomorphic, on your differential, you should be thinking about ischemia, structural heart disease, or idiopathic. So the characterization there, is it non-sustained, stable and sustained, or unstable? So non-sustained ventricular tachycardia, this is greater than 3 complexes, or basically greater than 3 PVCs, less than 30 seconds. If it's asymptomatic, you monitor and you treat the underlying cardiac comorbidities such as coronary artery disease or heart failure. If it's symptomatic, non-sustained VT, you want to do nodal blockade using beta blockers more than calcium channel blockers, and then anti-arrhythmic drugs. If it's stable and sustained VT, so this is greater than 30 seconds of ventricular tachycardia, then you want to do an anti-arrhythmic agent such as amiodarone, lidocaine, procainamide. We talked about the dosing of these drugs in the tachycardia ACLS video. Refer to that. And at any point, if the VT is unstable, you want to do synchronized cardioversion 100 joules if there's a pulse, otherwise defibrillation if there's pulse, if the patient is pulseless. So for polymorphic VT, on your differential, you should be thinking about ischemia, either acute coronary artery disease or cardiomyopathy, or prolonged QT. So you want to evaluate for ischemia and need for revascularization. If they're unstable, you want to go straight to defibrillation. If they're stable, excuse me, then you want to use magnesium 4 grams over 10 to 15 minutes. You want to increase the heart rate using isoproterenol, overdrive pacing. You want to decrease the QT interval using lidocaine. You want to avoid bradycardia using amiodarone and calcium channel blockers and beta blockers. And torsade de pointe, basically the same management, but it has a different morphology. So ventricular tachycardic storm. So this is greater than or equal to 3 sustained episodes of unstable VT within 24 hours. In this case, you want to use a lidocaine bolus if there's a prolonged QT. Otherwise, you can use amio bolus and the co-administration of propranolol 60 milligrams every 6 hours. You want to do anti-tachycardia pacing, so overdrive pacing at a faster rate than VT. This will help keep the heart stable. You want to treat and minimize the ischemia, so you want to revascularize if necessary and intra-aortic balloon pump to improve coronary perfusion, reduce the preload and afterload. You want to reduce the autonomic tone by intubation and sedation, stellate ganglion block, and cardiac sympathetic denervation. You want to call electrophysiology and the shock team, and catheter ablation if necessary.